Hi there, I'm Deborah Zaritsky with Grand Canyon University. Today is October the 14th, 2020, and this is for Dr. Valentine. So, talking today about dermatophytes. Initially, I wanted to do my presentation on ringworm, and then as I continued my research, I found these dermatophytes and how they're going to cause these tinea infections, which we will know as cutaneous infections. So when the skin is infected by a fungus, it's called a dermatophyte. And ringworm is one example of the several skin disorders that might be caused by this group of fungi. And they're going to be known as the epidermophytans. Kind of sounds like a Roman character. So derm sounds like skin, right? So what happens is that these fungi are going to be living on just the surface of our epidermis. So according to Weitzman and Somerville, the dermatophytes are usually restricted to the non-living cornified layers of the epidermic layer because of their inability to penetrate viable tissue of an immunocompetent host. So they're going to be producing an enzyme that I'm going to be talking about later that's going to kind of decompose the keratin there. So we do have three genera causing dermatophytosis. So this is where the conditions are going to start to formulate from these three different types of fungi. So we have the epidermophyton, as I said, the microsporium, and the trichophyton. So these different guys are going to affect the different integumentary system here. So we have the epidermophyton affects the skin and nails, microsporium affects hair or skin, and the trichophyton can infect the hair, skin, or nails. So as I said, the ringworm is caused by the dermatophytes. They usually hang out in the top portion of the epidermis. As I mentioned, we know from Warnock and Schiller that the dermatophytes can be split into these three ecologic groups depending on whether their usual natural habitat is in the soil or whether it is in animals. If it's in animals, we call that zoophilic species. And then we have the anthropophilic species that's going to be living on us humans. So E. flocosum is the species which is like a filamentous fungus identified by a hyphae microscopically, and we're going to see that when we go to get diagnosed for the ringworm, that's one of the tests that they're going to perform. So this E. flocosum was originally isolated from the Tinea cruris patient, which we're going to talk about here momentarily. So the cruris is within a particular anatomical space. So Tinea refers to the fungus there, so a gentleman by the name of Carl Otto Haars in 1870, he's the one that isolated this, and he found that they're going to be inhabiting the tropical and subtropical areas, and this is, as we know now, because of their affinity for high temperatures and moisture. So with these high temperatures and moisture come water, right? So we know that these fungi like to live in showers, baths, swimming pools. They're going to be on these formite objects, which is the towels, blankets, sheets, shoes, and other clothing. So E. flocosum is the only species in the genus of the epidermophytans. So recall those epidermophytans that I mentioned in the first slide. So they are going to belong to a family called the Arthrodermoaticae. Pardon my Latin. It's going to be a order of Onygenalis, a class of Uroteomycetes, so recall myco, right? It refers to fungus. It's in a subdivision of the, here's a challenge, Pizizomycotina and division of the Oscomycota. So tinea, we're speaking of Latin terms, is going to be Latin for worm. So, you know, in our early days there, before scientific discovery, often people thought that this was caused by a worm because of its kind of protruding circular formation, making kind of that wall there. But now we know that that is not the case. So we do have excessive heat, high relative humidity, and fitted clothing have correlations to more severe and frequent disease. Specific populations can also be predisposed to tinea, particularly the corporous, for example, children. So according to Yi and Abode, tinea corporis gladiatorium can present in athletes with extensive direct skin-to-skin contact, especially wrestlers. Patients with tinea corpuscus with close contact with cats and dogs are infected with the Microsporum canis. And again, recall that zoophilic species that does get transferred in the animals. So again, we have many of these tinea infections, and it just kind of refers to where anatomically is it on the foot, as we can see in athlete's foot. Is it in the groin area? Is it on the trunk? And so, you know, is it on the foot? Again, so we have the nail fungus. Is it on our head? Hence the capitis. So these different terms are just telling us where indeed this particular species of fungus is. So the author Hayner, as he points out, that the inhibition or failure of the skin's protective mechanisms or cutaneous infection might occur. So keratinolysis is a process that involves several enzymatic steps, beginning with the reduction of keratin, resulting in amino acid monomers. So after adhering to keratinocytes, if the arthrospores successfully evade a host and its immunity, they're going to adhere, germinate, and grow. And that's what's going to make the outward spreading papules that kind of make that worm kind of a formation. So how is it that if we do have this skin-to-skin contact and we know that it's going to be hard for this fungus to penetrate the skin, we're looking for areas of a portal of entry, right? So we do have, when we do have contact with this fungus, the first thing that's going to happen is the infective spores are going to be on the skin. And as I said, number 2, the adherence to the superficial cells occur. Number 3, the invasion of the keratin layers by the secretion of the keratinases, those enzymes that I was talking about. And then number 4, the keratinases are going to degrade the hard keratin that we find on those nails there into components which can be utilized by those dermatophytes. So I kind of put some body parts and just some symptoms here. So we can find this on the legs, the neck, the arms, and the trunk. And we are going to find some scaling occurring. And of course, with all other dermatological infections, you know, scaling is a wide seen symptom. So I'll talk about how we would diagnose that. So we're going to get that urethemia, that redness occurring with the vesicles and deep granulomas. So how do we diagnose that? So we would go to the doctor. We'd get a potassium hydroxide test to go ahead and segment those hyphae that are found within the fungi tissue. So this is a picture of what that would look like. And we would also utilize the Woods light technique and look for those areas of fluorescence and within the scalp or the skin lesions. So we would just take a small sample of that tissue. So how does this work as far as our immunity goes? So we would have a cell-mediated response, and that is correlated to a delay in the hypersensitivity and an inflammatory response. So there is a lack of or defective cell-mediated immunity predisposes the host to chronic or recurrent dermatophyte infection. So we are finding that this is an opportunistic infection to those that are immunosuppressant. So according to Brown, Harvey, Bowe, and Hodge, the humoral response produces the elevated immunoglobulin E and the immunoglobulin G4 antibodies that can be responsible for these atypical presentations or chronic infections. In talking about the complement system and our immunity, we have those CD4 cells that are going to respond to the viral antigens by producing the interferon gamma, leading to an inflammatory cascade. So the delayed type hypersensitivity, otherwise known as the DTH response, is dependent on the host, as I had mentioned, and their ability to fight off the pathogen and the host's previous exposure to the antigen. So generally, the delayed type hypersensitivity response is associated with acute infections with increased amount of inflammation, whereas the immediate hypersensitivity response is associated with chronic dermatophytes infections, such as the ones that I mentioned earlier, the ringworm and the jock itch and athlete's foot. A local wheal and flare reaction is the hallmark of the immediate hypersensitivity response, and it is unusual for an antigen such as T. rubrum to cause either reaction. So according to Whedon, the development of infection again depends on the exposure of the affected source and the various factors diminishing the host resistance. So how are we going to treat this? So usually it's going to be treated with a non-prescription antifungal cream that we can get at our local drugstores. So topical agents, lotions, powders applied to the skin for 2 to 4 weeks as a regime so that the fungus can discontinue to grow. So there are many available. Just some are the clodoramazole or Lotrimin, Miselex, the meconazole, and then they have a corticosteroid cream as well. So those are just to name a few. So the tinea capitis is capitis, we're going to find that on the head. It usually needs to be treated with a prescription antifungal medication, and that's going to be taken orally for 1 to 3 months. So creams, lotions, or powders don't work for ringworm on the scalp. Prescription antifungal medications would be used to treat that, and that would include Sporanox and fluconazole. So how can we avoid this? Oh my gosh, this is scary. It's in the soil. It comes from animals. It is on objects that, fomite objects that, inanimate objects. So how can we avoid this? Well, one is to keep our skin dry. As I had mentioned earlier, the fungus does like moisture and high temperature. So keep our skin dry, not to share personal items, avoid walking barefoot in public, avoid contact sports, as I had mentioned, like the wrestling, and avoid unfamiliar animals. Here are my references.